The most important pathway to understand when localizing motor problems is the corticospinal tract. Let's start by reviewing the course of the lateral corticospinal tract from the cerebral cortex to the peripheral nerves. Here's a list of structures that contain the upper motor neurons and the lower motor neurons, in order as they descend. We will discuss each of these structures. The corticospinal tract begins in the primary motor cortex, located here in the frontal lobes, just anterior to the central sulcus. The central sulcus divides the primary motor cortex from the primary somatosensory cortex, which is located in the parietal lobes. The primary motor cortex is somatotopically organized, which means that adjacent neurons in the primary motor cortex control approximately adjacent muscles in the body. The medial primary motor cortex, including cortex in the interhemispheric fissure, controls movements in the feet and legs. More laterally, there's control of the arms and hands. The face is further lateral. Important areas that require fine control, like the fingers and face, take up more space. Lesions of the motor cortex causes weakness, also known as paresis, in the corresponding areas of the topographic map. Paresis occurs on the opposite side of the body from the lesion cortex because the corticospinal tract will eventually decussate to the contralateral side before innervating muscles. The primary motor cortex receives inputs from the premotor cortex and the supplementary motor area, which are involved in motor planning. The premotor cortex is involved in preparation for movement. Lesions of premotor cortex produce slowing of anticipated movements. The supplementary motor area is involved in programming complex movements. Lesions of the supplementary motor area can cause problems with executing complex learned movements, called apraxia. Cell bodies in the primary motor cortex send their axons inferiorly through the cerebral white matter, known as the corona radiata. Here's a figure cutting away part of the left cerebral hemisphere, showing the corona radiata and how the corticospinal tract descends in the corona radiata. As the fibers in the corona radiata descend into deep brain structures, they become densely packed and become the internal capsule. The internal capsule passes between the basal ganglia and the thalamus. The anterior limb of the internal capsule separates the caudate nucleus from the putamen and globus pallidus. The posterior limb of the internal capsule separates the thalamus from the putamen and the globus pallidus. The corticospinal tract specifically passes through the posterior limb of the internal capsule. The fibers making up the corticospinal tract in the internal capsule continue to have somatotopic organization, with motor control of the arms located anteriorly and motor control of the legs located posteriorly. Following this, the corticospinal tract descends into the midbrain through the middle of the cerebral peduncles located ventrally. The cerebral peduncles are located here in the midbrain on this CT scan. Brainstem and spinal cord cross-sections are usually displayed with the dorsum on top, so from here on out we will be following the orientation on the right with the cerebral peduncles located here. Fibers controlling the lower extremities are located laterally, whereas fibers controlling the upper extremities are medial. From there, the corticospinal tract descends immediately through the ventral pons and the ventral medulla. In the rostral medulla, the corticospinal tract juts out from the ventral side of the brainstem a bit and forms a triangle in cross-section. Because of this, it's called the medullary pyramid. The pyramidal decussation is in the caudal medulla, where the medulla runs into the spinal cord. This is where the motor fibers cross over to the other side of the body. 90% of the fibers cross over in this way in order to form the lateral corticospinal tract. A small number of fibers stay in the same side and continue as the anterior corticospinal tract, where they play a role in motor control of the trunk. Overall, though, the lateral corticospinal tract is a motor tract that is clinically important. In the spinal cord, the lateral corticospinal tract runs laterally through the white matter and is somatotopically organized, with the lower extremities located superficially and the upper extremities located deep. The upper motor neurons synapse on lower motor neurons in the ventral horn of the spinal cord, which is a gray matter structure. The anterior horn is organized so that the alpha motor neurons controlling the extremities are located laterally, and those controlling the trunk are located medially. The alpha motor neurons send their axons out the ventral roots of the spinal cord. They join with the dorsal roots containing sensory information to form spinal nerves, like the ulnar nerve and the sciatic nerve, which then travel to distal structures. The motor fibers in these nerves synapse on the neuromuscular junction of muscle cells. Now that we've reviewed neuroanatomy, let's go through some tips for localizing problems in the motor system. Lesions to upper motor neurons and lower motor neurons both produce weakness, but have different patterns of findings on physical examination. Chronic upper motor neuron lesions result in hyperreflexia. We've already discussed Babinski's sign for the lower extremities, but you can also see Hoffman's sign in the upper extremities, which is where flicking the nail on the middle finger results in brief flexion of the thumb. You can also see the crossed adductor reflex, which is where tapping the leg adductor tendons on one side causes both the left and right leg adductors to activate. Upper motor neuron injury also produces spasticity, which is increased tone when an extremity is passively moved at high velocity. However, with enough force, there will be sudden relaxation from activation of the Golgi tendon organs in the muscle tendons, known as clasp knife phenomenon. You can also see clonus, which is rhythmic beating of a muscle group after sudden muscle stretching. It's best seen in the ankles. In contrast, lower motor neuron lesions produce hyporeflexia. You can also see fasciculations, which are nerve fiber bundles twitching at rest. Fasciculations are visible on clinical examination, but fibrillations are too small to be seen because fibrillations are twitching of single nerve fibers. Fibrillations can only be detected with electromyography. You may also find atrophy with chronic lower motor neuron injuries, which occurs because the muscle stops receiving growth factors from the lower motor neuron when the lower motor neuron is injured. Because the primary motor cortex and the primary somatosensory cortex are located right next to each other, with similar somatotrophic maps, lesions to the cortex can produce weakness and sensory loss in the same distribution. The anterior cerebral artery runs along the midline of the interhemispheric fissure, so strokes here produce weakness and sensory loss in the contralateral leg. The middle cerebral artery supplies the lateral convexity, so strokes there cause contralateral face and arm weakness and sensory loss. Because the surface area of the primary motor cortex is relatively large and is supplied by both the ACA and MCA, complete hemiparesis of the face, the arm, and the leg is less likely to be due to cortical lesions than lesions elsewhere in the corticospinal tract. The posterior limb of the internal capsule is more tightly packed, so lesions there can produce complete contralateral hemiparesis of the face, arm, and leg, potentially without any sensory loss. If a lesion occurs in the brainstem, it tends to produce signs that suggest brainstem involvement, such as cranial nerve abnormalities like problems with dysconjugate eye movements, or cross signs, which is when there is weakness or sensory loss on one side of the face and weakness and sensory loss on the other side of the body. Lesions in the spinal cord tend to produce a spinal level, where all myotomes below it are weak and all dermatomes below it have sensory loss. If there is a lesion in the nerve root from a radiculopathy, there tends to be weakness, pain, and sensory loss in a single corresponding myotome and dermatome. And if there's a mononeuropathy, there are characteristic patterns, such as the patterns in a median nerve palsy or a peroneal nerve palsy.